Hello, my name is Jean Dinwiddie. I'm co-chair of the Commission on Aging's Communications Committee. I'm subbing in for our regular host, Commissioner Katie Smith. Our theme this month is Healthy Aging, and we'll explore some of the healthcare options available in the county. Welcome, Dr. Khalil. Thank you so much for joining us today. So tell us a little bit about the Center for Successful Aging.
So thank you so much for having me. I'm really pleased to be part of your program. So our Center for Successful Aging, we actually opened, it's a very new center. We opened last August of 2021. It is a place or a clinic or a center where we provide a comprehensive geriatric assessment for older adults in an outpatient setting as a clinic. And older adults, meaning 65-year-old and older. We are currently located at the first floor of MedStar Montgomery Medical Center. And we have a full team. If you want, I can start telling you now about our full team.
I was going to ask, what can a patient expect when on their first visit?
Yes. So every new patient gets evaluated by our team. By our full team. Our first appointment is usually scheduled for 90 minutes, and we always tell our patients to expect a 2 hours visit with us. The evaluation happens usually with our medical assessment in the beginning, triaging the patient, getting vital signs, and then they usually get evaluated by our pharmacy team. So we have clinical pharmacists as part of our team, and they go over an accurate medication list. So we ask usually the patient to bring all their medication bottles with them, not only the list written. We ask them to bring all their over-the-counter drugs or vitamins or supplements or anything that we think it's safe because it's over the counter. And usually our pharmacy team will go over one by one, asking about how often they take it, what's the dose, who prescribed it, and all of it will be entered in the system. Then the patient will get evaluated by our physical therapist. So they get a screening evaluation for their functional ability at home. Do they use any assistive device or not? Any prior history of falling or not? Any prior rehab experience or not? And our physical therapists help us determine, does this patient needs a physical therapy course? And would it need to be on an outpatient or home health, home PT? So this is something our physical therapists will evaluate. Then we have our nurse practitioner, where she goes over all the medical history and she does the assessment. So we go over a cognitive or mental assessment, actually cognitive assessment for memory and different areas in the brain. And then we go over mental assessment, which is geriatric depression scale. This is also something we evaluate. She also evaluates the functional ability and with the ability to do their daily tasks for every patient. So this is all the assessment of the nurse practitioner. Then our social worker will meet with the patient and with their caregiver and go over how their situation at home, what type of social need they might have, and she helps with providing them with resources. And at the end, the geriatrician will go after listening to every single team member assessment. And so usually I go and evaluate the patient, do my full physical exam, and finalize the plan based on what I heard from other team members and based on the priorities for the patient, based on the goals of this patient and their family. What are they trying to achieve? And usually we finalize the plan, the medical plan moving forward. So this is our team, and this is only our first visit.
That is a comprehensive visit. I love the interdisciplinary approach to it. And I particularly love that you talked about the goals of the patient and the caregiver. So often you kind of feel that you're not being listened to. It can happen that you're not being listened to. It's like, well, it's the doctor's goals and not necessarily my goals. So the whole team approach. And so you mentioned also there's a social worker and to talk with the caregiver.
Yes.
That is so important.
Yes, actually, we recently started to do 2 at once. So our nurse practitioner will go to evaluate the patient and get the medical history. And at the end of her part, she starts the cognitive assessment. And this is when our social worker will come introduce herself and get the caregiver and sit with them one-to-one in our consult room. So part of our center is a specific consult room for the social worker with the caregiver, where she sits down with the family to listen to their struggles, to their challenges, to what their needs are. And during this time, the nurse practitioner is finishing her assessment with the patient. And the social worker, will also sit down with the patient and listen to what they need. So this is also a very important component, because we realize how much the social part actually is crucial as we get older. Our needs at home, do we have it or not? Is our setting safe for us to be at home? So this is how we build actually our team based on the 4 M's that we know it for as we get older, right? So our team was mainly built about what matters for the patient, the medication, memory, and mobility. And this is how we really establish the team, and this is how we try to do it in every
Yes.
Initial visit.
Well, as you know, I'm a pharmacist, so I love hearing that there are pharmacists involved, and that's sort of where it starts. So I have been seeing my my primary care physician for decades now, and I really like him. So how would a patient, but I also love hearing about your service. So would my doctor have to refer me? How does that work?
Yes. So we do serve in this clinic as a primary care if the patient wants to. If they don't have a primary care in the area, we have many patients who moved from out the state. But yes, to your point, we have many patients like you they have a very good relationship with their primary. They don't want to transfer, and they can come to us as a consult, as a geriatric consult. They can be referred by their primary care, or they can be self-referred. We get many referrals from the primary care, and we evaluate, we send them back our note. And the same for even if there is a self-referred and they want us to send our note to the primary, usually I will communicate with the primary and send my note to them. And we serve as a geriatric consultant for that patient in terms of, is it a polypharmacy, for example, a lot of medications, we're not sure what to take, what not. Is it for dementia or some mild cognitive impairment? Is it for recurrent falling? Is it for a tremor? Is it for beginning of Parkinson or depression? So usually we do the full comprehensive evaluation, as I mentioned. We send our recommendation to the primary, and if we think that we want or we need another specialist on board, usually we give our recommendation as well, that we recommend following with a specialist regarding 1, 2, 3.
Yeah, because I love my primary. His specialty isn't geriatrics, and he doesn't have access to that whole team the way that you do. So that is really so important. And just a 90-minute to 2-hour visit is also most impressive, because it's often 15 minutes in and out. It's a little bit. The pressures on the physician are a lot.
That's very true.
So
and this is how I'm sorry, but this is how we coordinate the care with the primary. So many times they will send us patients for 1, 2, 3, whatever they think that they need to, and we send them the note and we coordinate the care with them, so that we're there to help or to support the primary care caring for that patient.
So they become part of your team as well.
Yes.
That's wonderful. So in addition to this really comprehensive initial visit, then I understand that you also have, I think you're calling it an intensive outpatient unit. Tell us a little bit about that.
So part of our Center for Successful Aging is a section we call High Intensity Outpatient Clinic. We go by High Up, where it's also a clinic, but we are able to provide interventions to the patient so that we limit their need to go to an urgent care or to the emergency department. So we are able to provide services like IV fluid if they're dehydrated, IV Lasix if they are overloaded, IV nebulizer, putting a Foley catheter in or removing, doing stat labs, doing x-rays, transfusing blood. And this section is actually built in a way that any patient who is wheelchair dependent, they can also be pulled. So all the doors are very large, very wide, and they have a specific entrance so that we're able to push anyone like this in this situation. The only specific thing about our high up is that we need a referral from the primary care or from a specialist. So it's not self-referred. So we accept patients who are hemodynamically stable. There is no acute change in their functional or mental status, and that their specialist is sending them for a certain thing. So we got many patients for blood transfusion, for example, from their hematologist or from their primary care. We got sometimes from, we get from cardiology, people who need IV Lasix, and so that we can avoid sending them to the ER, they come to us to receive IV Lasix. We monitor their blood work, and they come to us as often as they need to. So it's all on an outpatient setting, understanding that our older people, our older adults might not do very well in the ER, especially if they have a baseline of memory problem or dementia. It will actually worsen the whole scenario. So we try to avoid it as much as possible.
And it makes sense that you would need a referral from a physician because of the services that you're providing there. A person wouldn't walk in necessarily and say, you know, give me, I need something for this excess fluid, please give me a diuretic, or, you know, that's not something the patient would say. So that is really an additional service that you offer. That's really nice. And to hear that it's constructed for people that have mobility issues is also really nice. I imagine that your entire center is constructed that way as well, right?
Yes, to your point, that's very true. Actually, all that, this is something, when it was built, it was like this, that the doors were very wide. The room is much larger than any typical primary care room, because we understand that the older patients will come with their family members. Many times we have at least one family member on board. We have one or two based on the need. So everything is set up in a way that we can have all of them if we want to discuss, especially at the end, if we want to discuss the goals of care or the plan moving forward. We have a place for everyone. Yes.
All right. I have my initial 1.5 to 2 hour visit. And then what about follow-up? I suppose, so I'm your patient now. I'm not, you know, through my primary care. Now I'm yours. You're my primary care physician. So then you'll see me for this, the whole team will see me. Do I see the team again? Do I see you? I imagine it depends a lot on what's going on with me.
That's very true. So usually the follow-up frequency is decided based on the clinical stability of every patient. Some patients might be in an acute heart failure, for example. I might see them every week. Some of them, they're very stable and they don't need to be seen more than once a month or once every 3 months. So how often we see them, it's really based on what's their situation, clinical situation, and what are the needs of the family as well. Regarding the follow-up, no, they do not see all the team. Usually on the follow-up, they see mainly the nurse practitioner, and I am available for any urgent issue or any consultation in terms of coming to check on the patient. So I am always available. Usually the follow-up with a nurse practitioner. However, also based on the patient, we might do the follow-up on a day where he will be or she will be evaluated by the social worker or by the physical therapist. So the team members are available for the follow-ups. However, it's not set up that all the team members will go to all the patients for the follow-up. However, if there is any active issue, then yes, they are available. Our follow-ups usually scheduled for 45 minutes.
All right. Still, that's a nice long visit to give you time. So this is wonderful to hear about, Dr. Khalil. Thank you so much. If one of our viewers would like to come see you, what's the best way to get in touch? What's the best way to learn more, to make an appointment? How do they get in touch?
So they can just call our number to schedule a new appointment. The number is 301-570-7400, and they can say that we're here to schedule a new patient visit. Usually we mail them or we email them an initial packet to fill some information. So filling it before the appointment will be very helpful. It's not mandatory, so we're going to see them no matter what. But if they're able to fill the initial packet where it goes over their medication lists or specialists or hospitalizations or functional status at home or social status at home as well. And we see them in the clinic.
Oh, thank you so much, Dr. Khalil. This has been so informative. And I think your Center for Successful Aging in Olney is, I can't imagine that you won't have a team of older adults coming in through there to see your team. So
Yes,
thank you very much.
Thank you for having me. It's been an honor.
Oh, my pleasure. Thank you.
Yep. Take care.
Thank you. Well, that concludes our program on healthy aging and some available options in the county for older adults. We hope that the information provided is useful for you. To learn more about the many services for seniors in Montgomery County, please visit the Montgomery County Seniors website at montgomerycountymd.gov/senior or call the Senior Resource Line at 240-777-3000. And as always, thank you for watching 50 Plus in Montgomery County.